Welcome to today's podcast. I'm Caroline, your host, and I'm thrilled to have you join us for this very important and informative episode. Today we have the privilege of speaking to Mr. James Smith, a consultant plastic surgeon based in Leeds. Mr. Smith specialises in melanoma, a critical area of healthcare that demands our attention and awareness. In our conversation, we'll be diving deep into the topic of melanoma. We'll start by understanding what melanoma is and why it is crucial for everyone to be aware of it. Mr. Smith will explain how melanoma is typically diagnosed and the common signs and symptoms to watch out for. We'll then explore the different stages of melanoma, how these stages affect treatment options and prognosis, and the current treatment options available. Mr. Smith will also provide valuable insights on how individuals can effectively examine their own skin for moles and what specific characteristics to look out for that might indicate melanoma. Mr. Smith will discuss the urgency of seeking medical attention and preventative measures to reduce the risk of developing melanoma. Sun protection plays a significant role, and we'll get expert tips on how best to protect your skin. We'll also touch on where you can find more reliable information about melanoma and skin cancer. And Mr. Smith will share some recommended websites and organisations. If you're considering booking an appointment with a melanoma specialist like Mr. Smith, he'll guide us through the process and what to expect. We'll also ensure you have his contact information for any further questions or to book an appointment. So let's get started. Thank you for tuning in, and let's welcome Mr. James Smith to the podcast. Welcome, Mr. Smith. So first of all, I wanted you to start by explaining what melanoma is and why it's important for people to be aware of it.
So melanoma is a type of skin cancer. There's lots of different types of skin cancer. And broadly speaking, we kind of divide them into non-melanoma and melanoma skin cancers. The non-melanoma ones are much, much more common. And so they're things like basal cell carcinomas, the squamous cell carcinomas, which I'm sure we'll cover in another session. But melanomas, which can be one of the most aggressive types, is essentially a cancer of the melanocytes. And the melanocytes are the pigment-producing cells that we have in our body. Obviously, some people have got slightly more of those, and some people have got slightly less, hence why there's different skin tones. But it's essentially a skin cancer of those types of cells.
So how is melanoma typically diagnosed?
Well, realistically, in order to diagnose it as melanoma, you have to remove it. And so there has to be some form of histological confirmation. Most of the patients present through to the GP with either a new lesion or a changing lesion. And if they've got concerns, in most circumstances, are referred through to some form of specialist, like a dermatologist, for example, who will remove it and then send it off to the lab. And then it's at that point that the melanoma is actually diagnosed. And then that kind of gets on to what you do after that. But it's a pathological, what we call diagnosis.
Okay, so what are the common signs and symptoms that people should kind of watch out for?
Yeah, so I think there's kind of a few sort of, I say misnomers, but preconceptions about what kind of patients get melanomas. Essentially, anyone can get them. Obviously, the paler the skin type, the more likely it is, because you don't have those protective mechanisms. Actually, darker skin types can still get melanoma, even though it's less common. The other thing to say is, people always think there's going to be some form of family history of it, and that's often not the case. And that it only affects people with lots of moles, but actually we get lots of people who've hardly any moles, and that's the only one that they've got. So most of the time, people either present through with a change to a lesion, and it might be something that they've had for years and years and years, and then it's changed over a period of a couple of weeks, a couple of months, a couple of years, or they've developed a new lesion. They've come from nothing, not sure what it's come about.
And could it be anywhere on your body?
Yeah.
It's not going to be like on your arm where the sun might hit it, or no?
Yeah, so it can be. So you can get it in any part of the skin. Obviously, the areas that are more exposed to the sun are slightly more common, but yes, you
Yeah.
can get it in areas that are not exposed to the sun at all. And in fact, you can get eye-based melanoma, which is very, very rare. You can get mucosal melanoma. So that's things like in the bowel, for example. That doesn't get any UV radiation, but it's still melanoma. And then you can
Really?
also get melanoma of unknown primary, meaning it's gone somewhere like a lymph node, for example, but we never find the original melanoma. And a
Well
small
then.
proportion of patients present through with that. So they develop sort of, a lump or bump under an armpit, and it gets investigated. It turns out to be melanoma.
Really?
Yeah. And so that's, the most common coming through. A lot of patients we get through, complain of symptoms of it. So, I've mentioned a changing lesion, and that's usually the thing to look out for. But things like itching, bleeding, it's not too uncommon. Quite often patients think they've done something to something. They've traumatized it. I caught that. And that may or may not be a red herring, or it may have made things slightly worse. But sometimes there's something that they think might have spurred it on a bit.
Okay. And didn't you have somebody once that had a melanoma on their foot? Like on
We
the
get
sole?
Yeah, and we get not somebody, quite a quite a lot
Quite
of
a lot of
people.
people, yeah.
Yeah,
Right,
so
yeah, lots of
it's not
people.
uncommon. Proportionally, of the
Yeah.
darker skin types, they're more common to get that type
Oh, right.
compared to the normal skin because they don't have the, you know, receptive melanocytes that they normally had. And we usually use it as an example. Bob Marley actually had foot-based melanoma. That's what he passed
Oh,
away with. So yeah, it's
really?
rare, but it can happen.
Okay. And so there's literally no common area where it could go to. It can go
Well,
anywhere.
yeah, technically it can go anywhere without sounding too paranoid. Yeah,
Yes.
technically you can get melanoma anywhere, but it's obviously the more sun-exposed areas that
Yes.
are slightly more common. But the non-sun exposed areas, you can still get, aggressive melanomas because of that as a reason. An area that's not been exposed to sun, sometimes it's more aggressive, and toe-based, foot-based, etc. is one of those
Okay.
types.
So what are the current treatments at the moment for melanoma?
So it's probably easier to talk about what happens if you have it. So
Yes.
I work in Leeds in the melanoma team, so a regional service. So we look after West Yorkshire, a bit of North Yorkshire, a bit of East Yorkshire, and a bit of South Yorkshire. So it's quite a big population group.
Yes.
And most of the patients who've come through to me have already had their melanoma removed. And so, they've had it removed, what we call a diagnostic biopsy. It's been taken off by either the GP, the dermatologist, or someone else. So they're coming for some further treatments. But fundamentally, having the lesion off is the most important part in that first step of the journey. So that's the bit I describe it to patients as, that's the lumpectomy and mastectomy when it comes to breast cancer with melanoma. That removal of that original lesion is the most important. And then once we've got that, not only have we got the diagnosis of what it is,
Yeah.
but all the different types of melanoma, the types of thicknesses of melanoma, because how far it's gone down into the skin layers defines realistically what we're going to do next. And then there's some other information that we can get from the pathology as well that can guide treatments. More commonly, surgical treatments are still the best way forward, but the first line for treatment of melanoma. So in most circumstances, you and I both know I deal with some of the more aggressive types, but in the vast majority of patients, they have the lesion removed, get the information, and then they need a little bit more surgery. And so often that's just taking a bit around the outside, like a 1 centimeter, we call a wide
Yeah.
excision. That's usually done under local anaesthetic. It's a quick day case procedure. And although it
Yeah.
has its risks, is usually low downtime. And in most circumstances, after that, patients have any form of follow-up either for a year or 5 years, depending what it is. The kind of additional things that we do, we can do something called a sentinel node biopsy in patients when it's appropriate. And essentially what that is if your melanoma was going to come back, the most likely place it come back is actually at the site of the original scar, so where it came from. So that's why we take a little bit more around the outside. But the second place it's most likely to come back in most circumstances is into a lymph node. And essentially what a sentinel node biopsy is trying to tell you is if it spread, which lymph node would it go to? And we've got loads of lymph nodes in our body, head, neck, armpit, groin. And what we're trying to find with this biopsy test is whether it's made that jump or not. And hopefully, in most circumstances, not. But it's a biopsy type procedure where we take the whole of the lymph node out, usually done under general anesthetic. And then once we've got the results of that, then we can tailor what the next kind of treatments are. And fundamentally, in most cases, that's some extra drug treatment. So broadly speaking, when we think about the different types of treatment in melanoma, we've got the surgical treatments, we've got the drug treatments, and then we've got some other specialist treatments. So drug treatments, usually it's things like immunotherapy, and immunotherapy is not chemotherapy, but it all sounds a little bit like that. But in a lot of scenarios, what we're trying to do is give you some extra drugs to try and reduce the chance of it coming back. And we use the term adjuvant. So adjuvant means giving you something to reduce the risk of it coming back. So in some cancers, that's chemotherapy. In some cancers, it's hormone therapy. Sometimes it's radiotherapy. But in melanoma, in most circumstances, it's what we call immunotherapy. And they've been the sort of great drugs for us over the last few years. We've got some other types of treatments. We've got something called targeted therapy, which is tablet type treatments. We've got things like doing extra surgery. So sometimes it's taking out more lymph nodes, what we call a lymph node dissection. We sometimes use chemotherapy. We sometimes use radiotherapy. We have drugs or treatments like electrochemotherapy. So that's using electrodes essentially with chemotherapy to try and target tumors. We have TVET, which is a clever thing that came around not so long ago, but it's essentially using a virus shell to deliver some immunotherapy drug. We have isolated limb infusion, which is using tourniquets and providing a little bypass of chemotherapy. And we've now, hopefully, starting to use a vaccine, or at least we're recruiting into a vaccine trial. So it's using the genetics of the melanoma to try and make a vaccine. But I know that's a long-winded answer, but essentially the great thing about melanoma is there's loads of different treatments, and they are rapidly evolving. And so the treatments are individualized, and in most of the major centers, we've got all of those treatments available.
That's amazing. It just sounds like it really depends on what type of cancer it is, where it is in your body, where it's spread, as to what kind of treatment you will get.
Yeah, absolutely. Yeah.
Yeah. So I was going to ask if people wanted to examine their own skin, what would they kind of be looking for in?
Yeah.
Can you run through that?
Yeah. So fundamentally, you'll see on lots of different websites the same thing. So there's different types of checklists that you can do. Most places advocate a sort of ABCDE approach. Now, what you're looking for in that is whether your mole shows signs of asymmetry. So whether it's nice and round, or it's sort of, you can't put a line straight through it, so it's asymmetrical. Whether you can draw a line around the outside of it, so whether it's got a well-defined border, whether it's what we describe as being homogeneous or heterogeneous, i.e. it's one color or lots of colors. The size of it, so diameter is the thing which is over 6 millimeter, and then whether it's changing, evolving. But I guess the problem is that most of us have got moles that look a little bit like that.
Yeah.
And what I tend to say to patients is, your moles are your moles. So, for example, I've got lots of moles, most of them all the same color. I've got lots of different sizes, but actually they're more or less the same kind of color of brown. If I had a teeny tiny mole that just suddenly developed that was 2 millimeters, just all completely dark, but very symmetrical, all those kind of things, but it had changed, it's new, that's abnormal for me. So I would still think about getting someone to have a look at that. And so what I tend to use is something called ugly duckling. And ugly duckling is where we look and say, which one looks different from the rest of them? And so often when we get a patient through, they say, oh, I don't know if you'll know which one it is. And we can go, it's that one. And it's not necessarily that it has that ABCDE criteria, but it just looks different from the rest. All right. Obviously, if you've suddenly developed a mole, then it might not fit those criteria. So if it's a new thing, it's come from nowhere, suddenly developed it, you've got symptoms, then that would be something to be concerned about. The other thing that we tend to say, the good thing that we have nowadays is quite good photography on our phones. And so what we tend to say to our patients who've got melanoma is to relatively regularly take photos and look on their phones. So, if you've got an iPhone or an Android phone, take what we describe as a macroscopic image. So, a whole image of your back, for example, and then closer ones in. Now, if someone comes into our clinic, what we do is we mark it up, we put little numbers and say, this is 1, this is 2, this is 3, and then we get medical photography to do it properly. There's no reason the patients can't do that at home. And it's quite useful to have those images to compare to. Now, obviously, we've got slightly different, better equipment in the hospital, but that's a reasonable way of checking moles as you're going along.
Yeah, no, that sounds like a good idea. And how urgent is it to seek medical advice? And is it really urgent, or does it depend on whether you've knocked it and it's bleeding, or?
Yeah, it's in some ways it's a difficult question to answer because I don't want to put too much pressure onto the GP practices here. But if you've got a concern that you've got a changing lesion, you've not had it before, then you need to book in to go and see someone. And we hear time and time again where people are just delayed. They don't want to bother people, but it'll be fine. That kind of thing. I'm afraid, as a general stereotype, men tend to be slightly worse than women at seeking medical advice. But, if you're convinced it's new, by all means, take a photo and see how it is in a week or 2 weeks. But, if you're worried, then get someone to see it. You're not bothering people, and it's usually a quick thing to get sorted.
Yeah. So what can people do to prevent themselves from potentially developing melanoma?
Yeah, so I guess it depends on a little bit of your skin type and family history. And obviously, if you've got family history, you've got previous history of it, then I'd say be even more vigilant.
Yeah.
What I would say, and maybe I'll be quoted on this or not, holidays and going outside are important to people. It's currently pouring with rain, and it's miserable. So it is important to get outside. It is important to get away. But you've got to be careful. And so what we tend to say is using factor 50 and applying it regularly. And if you go in a swimming pool, again, apply it regularly. Things have changed quite a lot in suntan lotion. So not only is the public perception of using suntan lotion changed compared to when we were younger, but actually the type of suntan lotions that you can get is much, much better. Previously a 50 would be completely white over your face and it wouldn't be functional. She's very good nowadays. A lot of people have got moisturizers with SPF in it, and that's fine if it's put, on your face, it's covering your neck, and it's got good UVA and UVB cover as well, and it's got, at least a 30, ideally 50. But what you really want to be ensuring is you're getting those areas that you're, either easy to miss or hard to spot. So back of the neck, around the back of the ear, etc., things like that. During holidays, when it's hot outside, hats as well, sunglasses, again, good sunglasses to protect you from UV, UVA and UVB for, with regards to, skin cancers you can get around the eye and in the eye. But it's just being vigilant about things and just being sensible. I'm afraid to say that the British population as a stereotype are pretty awful. We all see people going away, bright red when they come back. Or the other thing is we're not used to the sun that much. So when it comes out, everyone runs outside and forgets about it and goes, oh, it was a bit cloudy. It wasn't too bad. But then they're bright reds. So I would just say, have it in your car, have it round with you, have some at work, something so very simple so you can put it on. So
and also put it on your kids. We're reminded quite a lot by school to bring in suntan lotion, put it on, and even on cloudier days, you have to do this now. And it was something we never did when we were children.
Absolutely. And, as a different line, even if you're not doing it for that, we get a lot of patients coming in for cosmetic things, having facelifts or, all these kind of things. But yeah, quite happy to go and get, horrendous tans and go on sunbeds. But fundamentally, if you're going to spend a lot of money on cosmetic surgery, you don't really want to be going out in the sun. Because, not only you're high risk of skin cancers, but it really ages the skin. So, that's why you need the good cover from the both, UVA and UVB to cover you for aging skin and also to protect you from skin cancers.
Yeah. So sun protection is obviously really important. So it's important because you need that UV, which, go on, tell us about that.
Well, both.
Right.
UVA and UVB. There are different types of UV radiation.
Yeah.
Realistically, we're only really exposed to UVA and UVB unless we degrade the barrier even further, then we might have an additional one. The vast majority that's coming through is UVA, about 95% or so. That does go slightly deeper. That impacts on aging. It is attributable to some skin cancers as well, but it's usually the UVB that causes slightly more issues with DNA and makes things slightly more chaotic. So we tend to think about A being more of an aging issue and B mainly being to do with skin cancers. It's not quite that simple, but it's more like that. But you just need to make sure those two things are covered. And then obviously as well, if you're covering up, cover up with something sensible. With the kids, for example, you want to be putting the full swimming suits on that cover up to the arms and over the top. And it stops them getting cold and it covers them. It makes sure they're okay. And then when you're putting on the suntan lotion, make sure you're doing underneath those areas as well, because they're the ones that get rubbed off. But just making sure you're regularly applying it.
Yeah, so important, isn't it? I just can't believe we didn't quite understand it when we were younger.
Well, in some ways, there's not a lot of excuse for it. But in Australia, they've been well averse to it for decades. But we'll say that was because it's a broadly Caucasian population group that are affected with very, very good weather. So they've become averse to it. We're not, but we still do have the odd good weather here, and even despite that, we are still getting UV radiation, regardless of whether it's not sunny or not. So we're pretty poor. Education across the country, it's not great. I think it's getting a lot better, but it's only been more recently that people have stopped smoking as much, and now they're vaping, but don't pretend that they don't know if that's good or bad. And people still fundamentally drink and know it's not good for them. But some of it is freedom of taking people's freedoms away. And as I said, I think going outside and doing these things is really important to people. Just need to be sensible.
So yeah, definitely. So where can people find out more information about melanoma and skin cancer?
Yeah, so probably the best places that I push people to. Obviously, there's a cancer research website. It's very good, so it covers lots of things and lots of different cancers and Macmillan as well. But Melanoma Focus, I very much like. I think it's a very good website. It was set up by someone whose partner had melanoma, but that's got lots of information on. It is a lot based to do with patients that have got pre-existing melanomas as much as anything else, but it does have information there about melanoma. And then other websites I think are pretty good. The NHS has got some cover for it, the NHS website, if you Google, and then DermNet NZ, which is the general dermatology and skin cancer type website based in New Zealand. It's got quite a nice lot of patient information leaflets. Now, some of the treatments aren't exactly the same as what we do, but it does give you a lot of advice about what things are and what you might need to do about those things.
Okay, that's great. So if somebody wanted to book an appointment with you, what would they do and how would they go about it?
So obviously in Coppergate, we see patients. So if people are interested in coming in for a mole check in Coppergate, they can ring through to the clinic. I tend to use what we call digital dermoscopy. So I've got a dermatoscope which magnifies up the lesions, which then can be uploaded to people's records. So I think that's a really good way of trying to assess lesions and trying to see if things have changed. And in fact, realistically, NICE guidelines, which is our National Institute of Clinical Excellence, says that anybody that's assessing pigmented lesions should be doing it with a dermatoscope. So it's not a case of just having a look. You should be looking at it with a dermatoscope, and you should be trained to do that. So if people were interested coming through to Coppergate, obviously, with my NHS hat on, this is a fully funded thing that should be covered by the NHS.
Yes.
So, if people are concerned, their first port of call is always going to be the primary care.
Yeah.
And so, if they want to be seen in the primary care, phone through. Certainly around where we work, what happens is there's a very good telemedicine service. So usually you'll be seen, and they'll
By
get
your GP first. You must
by your
you go to
GP.
GP.
Yeah, and then what happens is they take a photograph, and then they can also take a zoomed in type photograph, and then they send it through to the dermatologists to have a look. And quite a lot of the time, they can make a decision about what to do at that stage, whether it be, no, absolutely fine, don't worry about it, or we're going to get you in and have a look at it, or we're going to get you straight in to have it surgically excised. So certainly around Yorkshire and quite a lot of parts of the country, they would be able to do that and get it sorted. So it's usually pretty quick. So I would say with my NHS hat on, the first port of call is always going to be through to the primary care rather than through to Coppergate. But if patients wanted to be seen, they can also be seen with us.
And so some people might come for regular mole checkups. If that's what they want to do privately, they can do that.
Yeah, they can. Yeah, so some patients come through just to have their moles checked. There is what we call mole mapping devices. So there are machines to look at different moles on people's bodies. A lot of those are done manually. So they have a little handheld thing. They look over and then they take photographs. Photographs are very, very good. But what you've just got to be careful about is if anyone's doing mole mapping on you, that they are part of a melanoma service, or at least they know what to look for. It's all very well taking a photo of something, but if they don't know what it is or how to interpret it, there's no point. So I would always make sure that you're seen by, a trained dermatologist or someone that looks after patients with melanoma.
Yeah.
We have in our NHS practice got some types of medical photography that we're piloting, and they're using AI. And hopefully that will be the future. So hopefully someone will stand like this, take a photo, and work out which one's a melanoma or not. They're pretty good. We've piloted quite a few of them. I don't think the technology is quite as good as we want it to be right now, but it is certainly getting there. And hopefully within my career, that will be something that people can have done.
That's amazing.
But in Coppergate, we use digital dermoscopy in photos.
Great, thank you. So I think there's loads more to cover, but we'll have to come back, I think, and discuss more about it because there's loads to it. So thank you very much for coming on today, and I'll put a link to you below where people can find you.
Thank you very much. Bye-bye.
Bye-bye.